الآن رايت
هذا البوينتر.
ده البوينتر ودي الماوس
الماوس
قدام ودي الورقة ودي البوينتر.
اوكي. السلام عليكم. بسم الله الرحمن الرحيم. As physicians, we don't only deal with diagnosis of disease. We sometimes deal with diagnosis of absence of disease. A person who comes for checkup, we are confirming absence of disease. And also, there's another job that physicians do, which is to diagnose absence of life when there is death. And although I don't like the term brain death because it may have a connotation of talking about an organ death. We are talking about death of an individual rather than an organ death. And I will show why this is the case. Now, why do they ask physicians to diagnose death? Because of the eternal fear of premature burial. And if you look at the stories and the history, the history is full of stories about people who were buried and then found out to be still alive. There was a story about George Battinson, who manufactured boxes of coffins with emergency bells that the person in the coffin, if he wakes up, then he shakes the bells and they can bring him up. And he became very rich. He was granted Order of the British Empire by Queen Victoria. This was at the time of Victorian time in England. Now, between 1750 and 1800, what were the criteria used for diagnosing death or else diagnosing absence of life? Cessation of heart action, respiration, and vigor, which is the motor activity. Or the lividness. Lividness is bluish discoloration. Bluish discoloration of the back. This was later on refuted as maybe occurring in illnesses without death. And we know if you look at patients in intensive care, sometimes if they have a problem with slow circulation, they start having bluish discoloration of their back because of it. It's a dependent area and it has stagnation of circulation. Then the rigor mortis. Rigor mortis is the stiffness of the extremities because of muscles becoming stiff after death. But that can be confused with muscle spasms in patients who have upper motor neuron lesions or with catatonia in patients with schizophrenia. Coldness of the body. First of all, they were touching the body and feeling that it is cold. But then in 1860, thermometer was discovered and they were able to check the temperature of the body. But that does not differentiate between inactivity because of hypothermia or hypothermia because of death. And then Davis sign or Lyon's sign, where you look at the arteries, they are non-pulsatile and they look pale and yellow. And then if you cut one of the arteries or vein, then there is no blood flow because there is no pumping. These are the criteria that were used up until 1800. Now, then they started looking at neurological signs, dilatation of the pupil. However, as we know, patients who have seizures, they will have dilated pupil, and dilated pupil may keep on going during the post-ictal stage where the patient will be not having any movement. So that is another caveat for using that. Lasher sign, which is the cornea becomes gray and opacified because of its dryness. There is no blinking. It dries up and it was. Then no muscle movement after electrical stimulation when galvanic stimulation of the muscles came on the scene. They started trying to see if the muscles would contract. And then depression of the loins, the buttocks, and the jaw because of dehydration that happens. All of these signs, if we look at them, they are changes that happen hours after death. They are cadaveric changes rather than immediate changes after death. And finally, putrefaction or putrid smell, that the decomposition of the proteins inside the cells and inside the muscles start secreting the very characteristic smell of corpses. Now, what happened is that before 1960, it used to be that a catastrophic event leads to stopping of the heart. The catastrophic event may be an accident, maybe cardiac arrest, and so on, but the heart stops. And at that time, if the physician comes and finds that the heart stopped, he will pronounce the patient dead, and that was easy. What happened in the middle of last century and going on, that resuscitation techniques came on the scene. And then some of those people who had a cardiac arrest or had an accident, they recovered. And we're still seeing this happening in the emergency room every day, that the patient will be resuscitated and then he will regain consciousness. However, not everybody resuscitation is successful. Some patients do not recover their ventilation immediately, so they need to be placed on mechanical ventilation. So they become dependent on the ventilator. If we can wean them off the ventilator and they can breathe on their own and then regain consciousness, they are alive. The other two choices is that the patient may have another arrest and he could not recover from his ventilation. The heart stops and then we pronounce him dead. The problem comes with this third choice, which is what is commonly called as persistent vegetative state, or what is more descriptively called as the wakeful unconsciousness. That the patient may recover his weakness, may open his eyes, but his consciousness is devoid of any content. He does not recognize anything. And I would hasten to say that this persistent vegetative state and the confusion between this and the death and brain death is the source of all the confusion in the minds of people. And they mix it and they say that there are people who recovered and so on. So we'll talk about it later on in more details. As I mentioned, the first report about prolonged coma came in 1959, and and it was called the coma dépassé. Coma dépassé, that is beyond coma, and it is a state of a person who has a dead brain but inside a living body. The body is still functioning. That's thanks to the areas of resuscitation that have developed by that time. So the need came that the termination criteria have moved from the heart to the brain. Why is that? Because we know now that resuscitation of the heart is possible. Number two, that you can resuscitate the heart. Every day, cardiac surgeons stop the heart intentionally in order to do operation, and then shock the heart back into pumping. So during that time, do we consider, if we say that stopping the heart means death, do we consider that patient was dead during his operation and then he woke up? That's not. That's why we needed to have more certain criteria. And remember, when we talked at the beginning about confirmation of death, a lot of people had advised in the past to delay burial of a person who was suspected of death. And the reason behind that, now we can explain that the heart, if it stops pumping within several minutes, that the brain stops pumping or becomes irreversibly damaged. And then that delay, what has been doing in the past is to confirm that the brain is irreversibly damaged, and that if we diagnose death, we are on firm grounds. So the two basic questions that we look for is, first of all, where is the essence of life? Is it throughout the body itself, or is it in a single organ, or is it in a collection of organs? And how can we avoid inaccurate diagnosis of death with maximal certainty? And this is what we are going to talk about the rest of the lecture. Now, where do life reside? Is it in a certain organ? Is it in all the organs? We learned that there are several levels of life. The very, very basic level of life is the cellular life. We have billions of cells in our body, and each cell individually is alive. However, does the life of a cell define the life of an individual? You take a cell and you put it in a cell culture, and it will grow. And even if the person from whom the cell was taken is dead, the laboratory will continue to culture that cell in the dish. So cellular life by itself does not define life. For many years, it has been known for people that there are certain cellular life that persists after death. The best example of that is if a person, the follicles of the hair, if you delay the burial of an individual who died and was confirmed dead, you find that by next day there is a little growth of the hair that he had shaved before his death. So the follicles of the hair have maintained growth, which is a very essential attribute to life. So cellular life is not a definition of an individual's life. So if we go up to, okay, now this is a cell culture. This cell culture is very interesting because it is called HeLa cells. HeLa cells are commercially available. You send $125 to a commercial laboratory, and they can send you a vial with these cells. These cells are used in many, because they are standard, they are used in many cytology labs around the world in order to test medications, to infect it with viruses, organisms, and so on. In particular, this is a picture of cells infected with chlamydia trachoma, and it is magnified about 400 times. Now, what is HeLa means? Yeah.
That email patients have cancer of the cervix.
Great. Great. Okay. So this was a patient who went to Hopkins, and she had the C of the cervix, and they took biopsy of the cervix, and they cultured the cells, and she died. She died back in the 1950s. Now, the laboratories are still selling her cells, alive cells, after she has died about over 60 years ago. The family of Helen Laxton, that these are the initials of her name, they are suing the laboratory for money. They are using their relatives' cells for commercial purposes. So that I'm bringing this to prove that even after the death of that individual, HeLa, had been alive for 60 years or over 60 years after her death. So that confirms the idea that cellular life does not define an individual's life. So cells come together, form organs. Do organs life, a single organ or multiple organs define life? I'll give an example. a person who donates a kidney to his brother, and then the donor dies for any other reason, the recipient still has a living kidney that belongs to a dead person. Can we say that dead person is alive because his kidney is still functioning? We cannot say that. So an organ life does not define the life of an individual. We talked about wakefulness consciousness, wakefulness unconsciousness, or persistent vegetative state. This is a problematic, we'll come back to it, a problematic area, because people think that it is equal to death. It is not, but it is a state of severe cognitive damage. The person, let's say, had an event, hypoxic ischemic injury to the brain. The brain has lost its ability to understand, ability to speak, ability to control movement. However, the appearance of that person may gradually become awake because he, with time, starts opening his eyes. But this apparent wakefulness is devoid of any content, any cognitive content. That's why some people are now moving from calling it persistent vegetative state, which indicates that this person cannot do anything for himself. He's like a vegetable or like a plant that you water and give nutrients and it continues to live. However, he cannot secure the necessities of living by himself. Or the more descriptive term that this patient is unconscious of his surroundings, but he appears wakeful. And then the top is the full personhood that every person has. Where do we draw the line between life and death? Definitely, person in persistent vegetative state is an alive person, but he has severe disability and is totally dependent on others. This is important for the definition that in many countries where people try to stop support, they need a court order to stop support of people with persistent vegetative state. And you probably have heard about Tericiervo, about other people where the family sought court order to stop support because it became very expensive and they could not afford it. Now, then we have to talk about, we drew the line, persistent vegetative state is not death, and other below that, it is probably death. What is the concept of death? Concept of death differs depending on what whom you're talking about. If you talk about individuals, about the majority of people, death is a transfer from this life to the hereafter, and the hereafter is part of the unknown to the living individuals. So it is ghaib, and the whole things that happen after death is we know about it only by what we have been told in the divine books. There is the legal definition. We have to have a very strict legal definition where we draw the line. Why? Because there are several legal consequences of death. The person would have his inheritance divided. His wife no longer is his wife, but she has to wait for prescribed time until she until she's eligible to get married to someone else. So there is a legal definition, and then, as we physicians we need clinical criteria, strict clinical criteria that we can rely on in order to make that definition. So it depends on the angle from which you are talking about this concept that you start. So we start thinking about what is the essential criterion for death? What are we looking for in order to say death has happened?
Stopping the family.
Okay, all what you are talking about are the signs, but what is the criterion? When we say a person is dead, what do we mean? Irreversible. That's the key word. It's that he's not coming back. Finished. That's why people get very upset about the death of a relative or death of a person that they like, because he went beyond the stage that he is irretrievable. He is so irreversibility is. If you ask people what is death, and they would say it is departure of soul. Well, yes, that's good. Departure of soul. Give me a sign how the soul departs. Can we put a person on a scale, and when he is dead, the soul departed, and then his weight becomes half a kilogram less? That's the weight of the soul that departed. No, soul is not something that we can touch or measure by our worldly science. There is another problem with departure of soul that I'm going to bring about. But the point that it was suggested by some of you is that the point of no return to life. So the concept of death is irreversibility. If we can define that this person is not coming back to life, then it is definitely death. The other point about the departure of soul, if we go back, soul, we don't know much about it except what we have been told in the Quran. If we look at Surah Al-Zumar, Allah يتوفى الأنفس حين موتها والتي لم تمت في منامها. So departure of soul happens not only during death, but also during sleep. So what happens to the soul that departs during sleep? فيمسك التي قضى عليها الموت ويرسل الأخرى إلى أجل مسمى. That confirms the irreversibility, that those people who are destined to die, when their soul is taken, it is not returned. This body is no longer useful for the soul to get into it and do the lively activities. But if this person is just asleep, the soul comes back and stays in that soul. And that is used to explain as well why during the dreams some people may see things that actually happen, that the soul had been exposed to things that is far away, and the person remembers that he saw something, but it was far away. It was not conceivable that he could have known about it, except by the fact that his soul had departed and returned. So what is the legal definition of death? Before 1968, all over the world, irreversible cessation of cardiac and pulmonary function was accepted, and it was easy to confirm. However, after 1968, the concept of reversible coma had came on the scene, and it took about 15 years to go into the legal definition, where the Unified Determination of Death Act was enacted in the United States, that you can define death by cardiopulmonary death or by what is called brain death. In the kingdom, there was a fatwa by the Riyadh Supreme Scholar Council in 1978 that if a person fulfills the criteria accepted for brain death, that taking off the support machines is permitted. Also, the Jurisprudence Council met in Amman, that's an international Islamic council, in 1982 also approved of the concept of brain death. Now, what is the clinical definition that we physicians use? We have to go back to the anatomy and look at the anatomy. Why do we call brain death as a death? Now, first of all, the brain generally is divided into a cerebral cortex and a brainstem and a cerebellum, of course, and then within the brainstem, within the back of the brainstem, which we call the dorsum or the tegmentum of the brainstem, there is a collection of cells. They form a network. They are called the reticular activating system. Reticular because they form a network like a reticular like a net, and this activating system, it is called activating system because it sends impulses to keep the thalamus and the cerebral cortex active. Now, the cerebral cortex serves for cognition and for voluntary movement and interpretation of sensory input, be it visual, be it auditory, be it somatosensory, and so on. The brainstem is divided into a midbrain, which serves the pupillary function and the eye movement, and it's divided into a pons, which serves the oculomotor function and also the corneal reflex. And we have in the medulla, we have the lower cranial nerves, which serve the pharyngeal reflex, tracheal reflex, and respiration. The most important part is the lower part of the medulla, where respiration is served. Now we come back to the reticular activating system. As I mentioned, it receives multiple sensory inputs and it mediates wakefulness. If you're asked about the area of the brain that a smallest lesion can cause the most devastating effects, it is the reticular activating system, and it is actually the rostral part around the aqueduct. If you damage this area, then you can put a half a centimeter lesion there and the person would be in permanent coma because of the interruption of the reticular activating system. The brain is no longer being activated. So, what is the difference between coma and brain death? Coma, it describes brain function at a moment, which means that it can be a transient condition. And it implies nothing about whether it is reversible or not, or about the prognosis. However, brain death, the most important part, that it is permanent and irreversible lack of brain. In coma, there is loss of brain functions related to arousal. However, in brain death, loss of all brain functions that related to arousal and related to other functions like cognition, like respiration, and so on. And in coma, midline brainstem or diencephalic compromise or generalized lesions. In brain death, the entire brain is destroyed by infarction or necrosis. Now, this is the difference. In a normally, we have to differentiate between the function of arousal and function of awareness. If one is awake and he is aware of what is going on, so he is normally conscious. If the person cannot be wakened up and is unaware of his surrounding, he is in coma. A person in vegetative state, or what I call wakeful unconsciousness, he started giving the appearance of wakefulness, so he is aroused, but he has nothing about awareness, so he is unaware. So this is the difference between normal consciousness, coma, and vegetative state. So wakeful unconsciousness or persistent vegetative state, the first criterion for it is that the person regains the sleep-wake cycle. And the sleep-wake cycle is mediated by the reticular activating system. Sleep is not an inactive function. Sleep is active function of the brain, because we know now through electroencephalographic changes that there are several stages of sleep, and these stages have also physiologic function. During the deep level of sleep, there is changes in the hormonal secretions that help repair the cells of the body and so on. So there is a function for sleep, physiologic function and psychologic function and so on. But the person, although he has normal sleep, he does not respond to environmental stimuli, and it is usually caused by diffuse brain injury with preservation of brainstem functions. That has a bearing on the prognosis. And prognosis is different whether the cause of vegetative state is post-traumatic or non-traumatic, which is a medical condition. Post-traumatic carries a better prognosis. If we examine the patient at 1 month and is still in a vegetative state, about 28% of them will be dead by 1 year, and there is chance of regaining consciousness at 1 year of 54%. If he persists in that state up to 3 months, then he has almost equal chance of being dead or being conscious or remaining in a vegetative state at 1 year. If we examine him at 6 months and he's still vegetative, his chances of recovering consciousness becomes lower, chances of persisting in this condition become higher, and he still has about 28% chance of being dead at the end of the year. Now, if the cause was non-traumatic, like the cause was due to cardiac arrest or septic shock or whatever, if we examine him at 1 month and he's still vegetative, he has about 50% chance of dying by the end of the year, or between 1 month and the end of the year. He has only a small chance of recovering consciousness, 14% by the end of the year. If we examine him at 3 months, he still has a chance of being dead. Of course, some of these have died in the interim between the two, and he has over 50% chance of remaining vegetative at 1 year, and he has only small chance of recovering consciousness. If he is vegetative at 6 months, he has less than 1% chance of recovering consciousness. So medical causes of vegetative state have a more serious prognosis than traumatic causes. Now we come to another case of perfect consciousness, which is called the locked-in syndrome. Anyone is familiar with locked-in syndrome?
Become alive and understands everything but cannot express or move.
Okay, that's very good. Actually, the picture here shows what is usually locked-in syndrome is related to injury to the basis pontis. Basis pontis carries all the corticospinal and corticobulbar tracts. So ventral pontine lesion can cause complete paralysis of all four extremities because of involvement of the corticospinal tract, and also causes involvement of the corticobulbar, so the person cannot talk. We determine a person is conscious by his response to speech or by his response to movement. If he is not moving and not speaking, we may think that he is unconscious. However, in this case, he has preserved consciousness. Why is that? Because the reticular activating system is dorsal to that lesion. It is in the tegmentum of the brainstem, and it is not injured. What is injured is the descending tracts, the corticospinal and the corticobulbar. However, the eye movements are rostral to this lesion, so we may have preservation, especially the vertical eye movements and the blinking. And that is the only avenue through which we can communicate with that patient. How do they communicate with this patient? I've treated some people with locked-in syndrome. The most famous of them was the late Ahmed Bilal. He had similar condition, and we were able to communicate with him, and actually his son did a good job on communicating with him by devising a communication board. Communication board is a cardboard that has the letters of the alphabet, and you pass your finger on the letters of the alphabet, and when you reach the letter that he wants to say, he blinks. So you take it down, and then you go back, and when you finish collecting the letters, you can see what he is trying to say. That was happened. The consciousness is preserved, and the patient is paralyzed except for eye movements and blinking. That happened to a person who is also he's a French author and editor of the feminine magazine called Elle. Elle in French means HeLa, and the Arabic version of that, LaHa. Okay, but he was born in 1952, and he became locked in at the age of 42 or 43. He was young at that time, but he became locked in, and he died about 2 years later. So during these 2 years, he was able to communicate with his wife, and she was able to collect a book. It's called The Diving Bell and the Butterfly. The book was translated into English. It's a small book, but he describes his experience with being alive, but why do they call it locked in? Yeah, it's like what Abu Ala al-Ma'arri said, رهين المحبسين. So Abu Ala al-Ma'arri was deaf and blind, so his two inputs were that he was able to move. This person, رهين كل المحابس, because he cannot move, he cannot عكس تماما وضع أبو العلاء المعري, because for Abu al-Ala al-Ma'arri it was the input, and this one was the output, is completely shut down. So he only was able to communicate through the ocular movements. Now, in the intensive care, we have to be very careful what do we communicate with the family. We have sorted out the locked-in, we have sorted out the vegetative state, we have sorted out the brain death, which we are going to talk about, but there are certain things that it is incorrect to use. I don't like using the word he is brain dead. Why is that? Because it indicates that there is an organ who is dead, but the rest of the organs are alive. He is on life support equipment. Are we really supporting life? He is dead. Once he is connected to the machine, he will be dead. Or he is kept alive by a machine. What is the correct answer to that? Instead of saying that he is brain dead, he is dead. Simply because when you determine, and there is a fatwa that you can consider him dead, it is not life support equipment. What we are giving mechanical ventilation. And mechanical ventilation is supporting the oxygenation of the blood. The heart is beating. You can take the heart out of the body and put it in a liquid, and it will continue beating. So beating of the heart does not define that the person is alive. He will be dead once disconnected. No, he is dead once diagnosed that he is dead. Or he is kept alive by a machine. No, we are supporting the organ function by the machines. So if we are precise in our communication, we can avoid a lot of misconception and accusation that, okay, they put the plug on him and they killed him. So what happens physiologically that leads to brain death? You can take this cycle from any point. Let's start from here, for example, or we can start from any other point. There was a neuronal injury. Neuronal injury was due to hypoxia, due to cardiac arrest. Then the injured neuron will swell. Also the same. The glial cells will swell. All the cells inside the brain will swell, and swelling will lead to increased intracranial pressure. And increased intracranial pressure will lead to decreased intracranial blood flow. Why is that? Because perfusion pressure of the brain is defined as the intracranial pressure minus the mean arterial pressure. The mean arterial pressure minus intracranial pressure. If the intracranial pressure exceeds the mean arterial pressure, that means the mean arterial pressure is the driving force. The intracranial pressure is the resisting force. If the resisting force is higher than the driving force, then there is no flow inside the brain. So it is incompatible with life. So that's the pathophysiology that happens. and that's where the downward spiral. No supply to the brain, more neuronal injury, more glial cell injury, more swelling, and then it keeps on going. In order to do the diagnosis, we have to respect essential preconditions, we have to do the exclusions, and then we have to do the tests. We can never skip these steps. You cannot go to test before you look at the essential preconditions and exclusions. So we have to keep all these 3 steps in mind, and they are well defined in the form that we fill out for diagnosing brain death. So, what are the preconditions? The event that led to current condition has happened over 6 hours ago. So there is a mandatory waiting period that is devoted for resuscitation of the person, for giving him all chances of recovery if that is feasible. Then there should be a positive diagnosis of a condition that usually leads to brain death. Not everybody who brought to the emergency room unconscious, we can say brain death. We say, what happened to him? Oh, he got in an accident and he has a lot of trauma to his brain and he has blood all over the place. Okay, that is something that is understandably can cause brain death. But a person who is coming without any clear history, why is he in this condition of coma? We have to make a positive diagnosis of what happened. Did he have a subarachnoid hemorrhage, massive subarachnoid hemorrhage that raised his intracranial pressure? Did he have a cardiac arrest that caused anoxia to the brain? And then the person should be comatose, deeply comatose, and not breathing. He needs to be on ventilator and no respiratory effort. If he fulfills all of these preconditions, then we can look what are the causes that usually and normally may lead to brain death. A massive subarachnoid hemorrhage, and as we can see on this CT scan, there is blood in the interhemispheric fissure, there is blood in the Servian fissure and over the insula, so there is blood everywhere, there is some blood even in the third ventricle. Another cause is cerebral hemorrhage. This is a person with cerebral hemorrhage that caused massive deviation of the midline, shift in the midline, and that caused the person to be in the brain death situation. Head trauma does similar thing. As we can see, there is depressed skull fracture, there is contusion of the brain, and there is a midline shift. Now, meningitis can cause generalized damage to the brain. These are all examples of conditions that lead to anoxia, and as we can see, anoxic brain shows hypodense areas in all over the brain. The brain has changed from a average attenuation to a very low attenuation to the X-ray beam. Once we have made the preconditions, then we go to exclusions. There should be no hypothermia, no metabolic or endocrine abnormality. Hypoglycemic patient may mimic brain death. He is not in an untreated cardiovascular shock, and he should not be intoxicated by sedatives like taking an overdose and so on. If we take step 1, take step 2, then we can go to step 3, which is testing, and testing is also 3 steps. One is to test for brainstem function, one is to test for the cerebral function, and one is to test for the respiratory function, which is in the lower part of the medulla. The brainstem function, and as we know, the brainstem is the site of all the nuclei for the cranial nerves. And we can test it in unconscious patients through testing for reflexes. Pupils, corneals, cough, gag, oculocephalic spans all the brainstem, and vestibulo-ocular. We'll talk about each one of these. Eye movements, or the very famous doll's eye movement. We shift the head of the patient to the right and to the left. If the eyes remain fixed in forward position and they don't move to the right or to the left opposite to the movement of the head, that means that there is no reflex and that the reflex is absent. The oculovestibular, we inject cold water, 50 cc of ice water, in the ear canal after looking to the ear canal, making sure that there is no blockage by the wax and so on. A comatose patient with intact brainstem will have his eyes deviated to the area of irrigation, and that is what we call caloric testing. If we inject and we don't get any movement, that is no response. Then we go to the next step, which is the brain function. The brain function, how do we test an organ that is not functioning? And we say that we are going to test this one. We go to, absence of function, how do we measure it? We measure the electrical activity of the brain cortex, or we measure the blood flow to the brain, because if the brain lost its blood flow, then it's not functioning. The EEG demonstrates cortical activity and not brainstem. However, suppression is possible in the clinical setting. Isoelectric electroencephalogram, in the absence of severe sedation, overdose of phenobarbital or pentobarbital, it represents absent cortical function. Blood flow studies, absent cerebral blood flow is incompatible with neuronal survival. The hypothetical mechanism of absent perfusion, we talked about it, if the ICP exceeds the mean arterial pressure, or else that there is the so-called no reflow phenomenon, that the vascular endothelium inside the brain, when exposed to anoxia, also will get injured. So the vascular endothelium in the capillaries will swell, and the capillaries have a small lumen. If you get swelling of the endothelium, you shut off the circulation. If we decide that the brainstem is not functioning and that the cortex is not functioning through the EEG or through angiogram or whatever, then we go to the apnea testing. Apnea testing is the gold standard for seeing. Why apnea testing is important? If we look about the root of the word, nafas and nafs. Nafs is used for life, for ruh. Nafas is for breathing. It has almost the same root. If there is no breathing, there is no life. Now, if the person is capable of moving air when he is challenged by high level of PCO2, then he is not dead. He is still able to do that. However, during the test, we have to protect the brain and other organs from the effects of hypoxia, and we have to observe closely. This is the idea about the testing for apnea. So how do we do it? First of all, we pre-ventilate the person with 100% oxygen. We don't change the setting of the ventilator. We don't want to lose CO2. We have normalized his blood gases, PCO2 around 40, it's fine. But we want to push in as much oxygen as possible, not only to saturate the hemoglobin, but also to dissolve some of the oxygen within the plasma so it can carry the person over the period of testing, because we are not interested in the effects of hypoxia. We are interested in the stimulatory effect of hypercapnia on the respiratory center. Then what we do, we disconnect the ventilator and we supply O2 through an intratracheal catheter that goes to the level of the carina, and we set it up to be 6 liters per minute. So we are supplying a continuous flow of oxygen. By passive diffusion, the continuous flow of oxygen will give some supply of oxygen and will not wash out CO2, will not act against us because we want CO2 to accumulate. During this time, we observe the patient through monitoring of his heart rate, arterial blood pressure, oxygen saturation, and respiratory movement, either by visual or by electronic electrodes on the chest wall. And then we wait for about 10 minutes, and if we had to conclude before 10 minutes, we have to make sure that the PCO2 have gone above 60 millimeter of mercury. So we take the blood gas before the end of the test. If we have exceeded 60 millimeter of mercury or 20 millimeters above our starting level, then we have watched the person for the 10 minutes and he did not have any respiratory movement. We say that he is incapable of breathing. The apnea test is positive. In children, it is similar, but since children brains are more capable of regeneration and so on, we have to be more careful in determining irreversible injury. So the conditions are coma and apnea, normal blood pressure and temperature, flaccid muscle tone, absence of spontaneous movement, reflexes are acceptable, absence of brainstem functions, pupils non-reactive and so on, cough and reflex. However, what is different, these are all similar to the adults, but the difference is that with age, if the child is under the age of 1 year, we have to do 2 clinical examinations separated by 24 hours and 2 electroencephalograms separated by 24 hours. If he is less than 1 month, then we have the 2 examinations separated by 48 hours and 2 electroencephalograms separated by 48 hours. These are the differences between adults and children. We have to have a longer waiting period. Now, this is a relatively old, 12-year-old study that was done by Whiting, who is in Mayo Clinic, who is a neurointensivist, and to see in 77 countries what are the criteria for diagnosing brain death. Now, time between examinations have varied from 6 to 72 hours, and the criteria that is used in the kingdom is similar to that. Exclusions required in all 77 countries, including by the way, the survey was sent to us in the kingdom and we responded to it. Apnea test, interestingly, is only required in 41 countries, about 60% of those people. So the kingdom is requiring apnea test. Confirmatory tests like an electroencephalogram or blood flow to the brain and so on is required in 26 countries. The kingdom is one of them. Written laws or guidelines are available in 67 countries. The kingdom is one of them. In 32 countries, 1 physician is sufficient. However, like other 33 countries, 2 or more physicians, the kingdom requires 2 physicians to decide on the testing. So I'm displaying this to show that the criteria that are used in the kingdom are intentionally strict enough to avoid any mistakes in determination. Yes?
That after the confirmatory test, they started the diagnosis, he's not brain dead.
If the criteria are followed and they are properly applied by a person who is trained and knowledgeable about this, there has been no person who came back to life. Now, what is going on now in many places is that some people try to hang on to the last straw. So there is the so-called, along with the brain death, there is lack of the function from the pituitary. And therefore you have diabetes insipidus, because there is no secretion of ADH from the posterior hypophysis, and there is the no secretion of ACTH, no secretion of TSH. So what they do, they give triple hormonal therapy. They give nutrients by hyperalimentation, and they support the blood pressure and so on and so forth. Some people who have been diagnosed as brain dead, in the past, people who were not subjected to these extensive heroic measures, usually the heart stops within 2 to 3 weeks. And we used to say, okay, the heart will stop in 2 to 3 weeks. When they are subjected to these measures, the organs, you are using a testing preparation of organs. So you are supplying the organs with the necessary things, and you are supporting the organs. Nobody had recovered, but extended survival of organs after diagnosis of brain death is being recorded now, and it's been recorded for months and so on, but still no single person recovered consciousness or did not die. Eventually, the heart will stop after 2, 3 months, 5 months, up to a year, if depending on the intensive care that is given. Yes.
إذا ما كان في willing to donate half of the value and donation, do you stop the management of the cerebral maintenance?
Okay. Now, the fatwa allows disconnecting the ventilator because it was clear in fatwa against 1978 that if there is no chance of him recovering, and the fatwa states, I think that they will distribute copies of it. If the EEG is flat, then you can disconnect the ventilator, because this kind of management becomes what we call futile. Futile is abath, that you are occupying a bed, you are using resources for something that is definitely hopeless. So you can disconnect the ventilator. Now you come to the social application of it. Several families go into a stage of denial, like it's a normal reaction. That you tell them that he is dead, and they go to the stage of denial before they accept that, and they say no, do everything and so on. So what has been happening is that physicians have been reluctant to disconnect the ventilator. But what they do, they say, okay, it was confirmed, so there is no need to give, for example, the dopamine or to do, naturally there would be some kind of a passive rather than active disconnection of the support. Yes? Why do you have? Okay, because it is not, in the past they used to say that might be that the dead organ, which is the brain, may release some cytokines that affect the cardiac function and conduction. A lot of people, as you know, treatment in intensive care is not innocuous. There are a lot of risks for ventilation. The best known is ventilator-associated pneumonia, the VAP. And the majority of them will get accumulated secretions, and they get pneumonia, and then the heart will stop because of infection, because of additional hypoxia and additional toxic material that is released from the infected lungs. So there are many causes that happens. Yes? No, it's not to cause coma. And this is what I was trying to explain, that coma is not brain death. Brain death indicates that it may damage, if it is an irreversible damage to the reticular activating system. You get irreversible loss of consciousness. But loss of consciousness is not equivalent to death. Death requires loss of all brain function. Yes.
دراسة أنا ما أعرف أصلا حتى لو كنت كيف تقارن صور سنة الدكتوراه إنه قعدنا أطباء وقعدنا مستشفيات نفس الدرجة ولا بعض حالات البرين فيها موت.
Okay, I'm fully aware of this. Dr. Yusuf Ahmed, when he was he was supposed to meet with me and to explain to him some of the concepts. He's not a physician, he's Sharia. The study that he did, I'm astonished that the committee that gave him a doctorate on it, because it is extremely flawed study. And there is no logical cause and effect with it. What he did, he went and surveyed physicians in peripheral hospitals and asked them if they know the criteria of brain. And the majority of them did not have special training or special lectures to know what is brain. So each one of them gave him a different idea or said, I don't know. So he did the statistics and he said that the physicians are not in agreement on the criteria. Physicians don't know what is the criteria. So the whole concept is wrong. And this is what he came up with. And I'm surprised that those who discussed it with him, they did not follow the essential scientific methods in judging thesis. When you judge a thesis, you have to see if the logical cause and effect are connected and whether the proper steps are taken in order to reach from A to Z.
So there is no supposed to know mistake much.
Yeah, well, there are plenty of. This is why I said most of the problems that we get is in the differentiation of the concept of vegetative state or wakeful unconsciousness with brain death. Now, vegetative state is a state of severe disability. The disability involves cognition, involves speech, and may involve movement. May or may not involve movement. Now, if you recall that when I put the picture, the pyramid, the vegetative state is not one single entity. There are light vegetative state, there are severe vegetative state, and actually between, I will not go into that detail, between light vegetative state and full consciousness, there is an area which is called the minimally conscious state. So we are looking at the spectrum, and if one is not well aware of the different levels of function of the central nervous system and different effect on the consciousness, then they can make mistakes like anyone else. Any other questions? Thank you.
Any questions you want to ask before we
continue recording. Continue recording. حوقف أنا.
Okay.
any questions?
حسبت شيء فلاش أو شيء.
Okay.